So in the next 40 minutes, I'm tasked to tell you about all things of the ankle. So we'll start with this one. I have no disclosures, but since this is a ski meeting, this is an unknown here, but I think a lot of you already know what this is. So on the radiographic examination, we can see the osseous fragment along the lateral portion of the talus. And this is proven nicely on the sagittal and the coronal reformatted images from the CT scan. So this is that classic snowbird's fracture. Everyone seems to be walking normally here, so I suspect everyone made it through the first day of skiing A-OK. No St. Patrick's Day leprechauns got you. So how I structured this talk is actually just based on my dictation macro. So I start with some of the common pathology. We'll take a tour around the tendons, finish up with ligaments, and also some impingements, and then, of course, the dreaded OCD or the osteochondral defects. So I'm going to start with the big guy here. This is a 52-year-old man with chronic Achilles pain. He had had a previous injection around the Achilles tendon about a month previously. So I wish all of these Achilles tendon ruptures could be this easy, where you can see this large fluid gap here and really no tendon identified in the area of the Achilles tendon. Don't let this little wiggly guy kind of fool you. If we look at the T1 weighted sequence, we can see that that is actually fat that's infiltrated with a little bit of edema as well. We can almost imagine on the the lateral radiograph of the ankle that we can even see that there's a large gap here suggestive of the Achilles tendon rupture. So before we move on, we have to understand some of the unique anatomy of the Achilles tendon. We know that this is a tendon and sometimes called the triceps sura, which is because we've got portions from the soleus as well as the gastrocnemius tendons. So as these three portions come together, they actually undergo this spiral twist around the distal ankle and the leg. And it is thought that during this location, there's actually relatively tenuous blood supply, which leads to the propensity for the Achilles tendon to develop tendinosis, as we see in this axial image. In addition, we have to remember some of the other features, which I think can be a little bit confusing. Sorry, there's a typo here. This is supposed to be peritenon and not paratenon, so that is my mistake. I'm so sorry. But this is to highlight one of the unique.
Good morning, everyone. And in this talk today, we're going to talk about some CNS infections. So I thought, we can review some interesting CNS infection cases. Specifically, I picked the one that they have unusual imaging manifestations and the ones that imaging can actually make a difference in terms of early diagnosis and can affect the prognosis in some of these cases. And then for each case, we review the key imaging features and I'll summarize some take-home points for each individual case. So case one, this was a young woman presented with right-sided weakness and stroke code was activated. So we have a non-contrast CT here and CTAs is just part of the stroke protocol that was done. And you can see that there are some hypodensities in the basal ganglia and internal capsule. If you look at the CTA, this is a very abnormal CTA for a 38-year-old. Lots of irregularities. If you look at these ACA branches, for example, here there's a focal stenosis, and these MCA branches are kind of like ratty and irregular. That's not, it wouldn't be unreasonable to raise the possibility of maybe CNS vasculitis. Atherosclerotic disease is still possible, but, it would be unusual for this age. They follow this by MRI. At this point, basically, the clinical suspicion is basically stroke, code stroke. And you can see in this MRI, you can see in the regions of hypodensity, you can see reduced diffusion in the basal ganglia, in the internal capsule there. And then, even on the other side, there are some small areas of reduced diffusion in the thalamus and posterior limb of internal capsule. So sort of bilateral infarcts, predominantly in the basal ganglia, deep gray. A little bit of history was given to us. This patient was started on immunotherapy for RA just a few weeks before, and also had history of low-grade fever for several weeks. So this is as part of our stroke protocol, because the patient, again, the possibility of CNS vasculitis was raised. So vessel wall imaging was performed, and you can see that there is a significant leptomeningeal enhancement in the supracellular cisterns, in the basal cisterns here, perimesencephalic cisterns. You can see that this is basically the MCA branches, and you can see a lot of enhancement around the vessels.
So, and this is basically kind of leads back to what we've been talking about kind of the last 4 days. MRI, we now hopefully know that's the test with the best sensitivity, good specificity. We're independent of breast density. This is the most accurate modality for assessment of lesion extent. Contrast-enhanced mammography comes close, but MRI is still the most superior exam, and we have the ability to detect also non-invasive breast cancer. When we look at the indications, this is a case where the patient had her baseline mammogram, no known family history because adopted, and she had on her initial mammogram tons of microcalcifications. And that was kind of before the time when MRI was established for kind of just a staging, and in particular that was the time when the mantra was we have calcifications, MRI is not good for that, we don't do that. So in that case, she participated in the study, and we saw after her biopsy, because you can of course do an MRI after biopsy, we saw a segmental heterogeneous non-mass enhancement way exceeding the microcalcifications, which actually makes sense because that was a high-grade DCIS on biopsy. High-grade DCIS on biopsy is the microcalcifications are often just the tip of the iceberg. If a biopsy yields a low-grade DCIS in a 3 millimeter cluster, I would not expect much more on MRI. So you can also make that the use of MRI in this context of microcalcifications dependent on what histopathology tells you. In that case, that was confirmed. That was really all disease with several foci of microinvasion. Also, when the indication staging as such has changed the importance of the role of MRI, in the sense it used to be when you called something multicentric, that would mean no breast conservation. Nowadays, multicentric with two lumps in different quadrants, or multicentric in the sense that it spans over more than one quadrant. With oncoplastic surgery, there's so much is possible, so that also not necessarily means that this will be a mastectomy. And the importance of MRI has also significantly increased. So we are really there to give a good surgical roadmap to allow the surgeons to achieve clear margins with nice breast conservation outcomes. Scar versus recurrence, this is the application where MRI is definitely extremely helpful. These patients represented approximately the same time out of surgery, both 1.5 to 2 years out, with the same symptomatic. Both had a palpable area of concern at the lumpectomy site. One has a florid fat necrosis, which can look terrible on conventional imaging, and the other one had her recurrence of a very aggressive cancer. So an MRI can clearly and easily distinguish between those two. An application of MRI that is more and more used, except